Good morning. My name is Dr. Kathy Pushkash, and I'm the clinical educator with the BC Centre for Excellence in HIV/AIDS. Welcome to Chapter 3 of the BC-CfE Anniversary Conversation Series. This year marks 30 years since the creation of the BC-CfE, and the aim of these events is to celebrate and commemorate the journey and the accomplishments of the community advocates, researchers, and healthcare providers that have worked to turn the tide of HIV in British Columbia. Today's session is titled Improving Access to HAART in BC, the STOP HIV/AIDS pilot project. Dr. Rolando Barrios is Senior Medical Director at the BC Centre for Excellence in HIV/AIDS. Rolando has training in family medicine and public health and has held several leadership positions in Vancouver Coastal Health, where he led important health system changes. He currently leads various programs and initiatives at the BC-CfE, including epidemiology and population health, pharmacovigilance, quality improvement, and more recently, the implementation of the Hope to Health Research and Innovation Centre in the downtown east side of Vancouver. Rolando has been involved in the planning, implementation, monitoring, and evaluation of the STOP HIV/AIDS project in British Columbia. Irene Day is a registered nurse with a master's degree in business. Irene worked for the BC-CfE for 16 years, serving as a senior director. For the past 2 years, Irene has worked for the 625 Powell Street Foundation, a philanthropic organization with strong ties and support to Dr. Julio Montaner and the BC-CfE. Following the presentation, Irene Day will be joining Dr. Barrios for a conversation about their experiences with the STOP HIV/AIDS program during this time and moderating questions from our audience. I'd like to take a moment to acknowledge with gratitude that our place of work is on the traditional, ancestral, and unceded territories of the Coast Salish Nation, the lands of the Musqueam, Squamish, and Tsleil-Waututh. This acknowledgement is a reminder of the discriminatory, racist, and colonial practices that have had a lasting legacy and continue to create barriers for Indigenous peoples in our healthcare system. If you have any additional questions after the webinar, please email your questions to education@bccfe.ca. We would also like to take a moment to acknowledge the BC-CfE communications team, the clinical education and training team, and the IT team, who are integral to the functioning of the webinar learning series. This program has not received any financial or in-kind commercial support. The content of this presentation has been developed by the presenters. I will now pass the microphone to Dr. Rolando Barrios.
Over the next 15 minutes or so, I will attempt to summarize for you the history of STOP HIV/AIDS. Seek and Treat, as we originally got to know STOP, was conceptualized by Dr. Julio Montaner in response to the emerging evidence of the benefits of highly antiretroviral therapy, also known as HAART, and the pressures to contain the antiretroviral costs in the province of British Columbia. Seek and Treat, as I will define later, is a policy direction supported by many actions which were delivered by local health services and agencies and many other stakeholders involved in this process. I will attempt to define STOP HIV/AIDS, describe the trends in HIV/AIDS prior to 2010, the introduction of the initiative, summarize the unique characteristics of the STOP HIV/AIDS pilot project and how it addresses regional trends in HIV/AIDS, and describe the legacy of the project as it expanded provincially and how the program is inspiring applications into other health conditions. I'm just going to remove my mask to get a more clear message here. So in 2006, coinciding with the 16th International AIDS Conference in Toronto, Dr. Montaner wrote an opinion piece on the Lancet Journal describing what many considered controversial at the time and a true innovative idea. He outlined the evidence of antiretroviral for prevention. He talked about how HAART reduced the plasma viral load to undetectable levels, how mother-to-child transmission was being halted by use of antiretrovirals, and how the post-exposure prophylaxis was also being managed with antiretrovirals. And there were some early emerging evidence at the time on studies among serodiscordant and heterosexual couples that showed decreased transmission. He also was able to, using some of the data that I'll show you later, to show the impacts of antiretroviral therapy by decreasing the morbidity, as in the AIDS cases across the province, the mortality as also a decrease on the HIV AIDS-related mortality, and transmission as the number of new diagnoses were decreasing. He concluded that highly active antiretroviral therapy was not only good for the patient in halting the progress of HIV, but also good for the system as it prevented transmission, but also good for the pocket as it actually decreases the cost of managing HIV and containing the epidemic. This notion, as you can imagine, resulted in significant debate and fears of medicalizing the traditional prevention and ignoring all the psychosocial factors that and needs that the HIV population were experiencing at the time. Furthermore, policymakers and funders were concerned that the cost of scaling up therapy was too high and was not possible to scale that up. This notion was later proven to be valid. 5 years later, at the 2011 International AIDS Society Conference in Rome, the results of the randomized clinical trial under the number HTPN 052 showed that out of the 1,700 serodiscordant couples randomized to treating the HIV early versus delayed therapy, there were only 39 HIV transmissions, and out of them, 28 were virological linked to the partner, the infected partner, sorry, and only one occurred among the early treatment group. This plainly validated what Julio has actually proposed at least 6 years earlier. And this is the data that Julio used for building the case for treatment as prevention and how that worked for population level. This data, as I suggested, illustrate the impact of HAART on the decline of new diagnoses in the province of British Columbia. The blue line shows a rapid increase on the number of people on antiretroviral therapy, and concomitant to the increase of antiretroviral therapy, we saw a decrease depicted here on the red line, and later on some plateauing on the numbers of cases. Concomitant again with the plateauing also on the antiretroviral therapy treated population. Since then, from early 2004 and before the launching of STOP in 2010, we also noticed another increase on antiretroviral therapy, mostly to do with the evolving guidelines of therapy and abandoning the initial concept of waiting until people have CD4s of 200 or less to initiate therapy, and was a bit more liberal at the time. This increase again in the blue line was concomitant again with another decrease on new cases, and that led together with the documented decrease on the AIDS incidence and AIDS-related mortality after the introduction of HAART in '96, and then leading to the introduction of STOP pilot in 2010, we still saw the decline of about 85%. Unfortunately, this decline was not across the province. There were some inequities in the benefits of antiretroviral therapy, and we noticed that in Prince George and the Northern Health, here depicted in red, was the only region in the province that was experiencing at the time that this study was released in 2006, where increasing mortality was present. Similarly, we also noticed a significant difference between the residents of the Vancouver area, particularly comparing the residents on the city center as depicted on the left side bottom chart, compared to the individuals living in the downtown east side, were experiencing also a decrease in mortality, but not at the same rate as those living in the city center. This led to the launch of a pilot and the justification of a pilot. So it's not really was due to an increase in increase in HIV cases, but mostly to do with inequities in mortality that's why this pilot project was launched in this particular areas. And here in 2010, the picture of the launch, the then Minister of Health announcing the allocation of $48 million for the Seek and Treat pilot project that it was to be focused on Vancouver and Northern Health, particularly in Vancouver, downtown Eastside, and Prince George. And that was earmarked to treat and prevent HIV. You can see here on the right side of the picture some of the players that joined that day. And Irene, I'm sure, will be chatting more about this, but trying to summarize this in 5 minutes is a kind of a very complex task. So what STOP HIV stands for? So as I suggested before, it was early known as Seek and Treat. And Seek because the idea was to find those unaware of their HIV positive status that may be contributing to the ongoing transmission of HIV across the province, but also finding those who were aware of being HIV positive, but for various reasons were disengaged from care and treatment. And they needed to be re-engaged in order to not only benefit themselves from the treatment, but also to halt the transmission of HIV. And of course, the other component was the treatment of antiretrovirals. And the idea was to offer antiretroviral therapy to those willing to be treated. So it was never intended to force anyone to be on treatment. And also address some barriers and provide supports for improved adherence to the treatment so they will realize the benefit, which was viral load suppression. And these two components will lead to optimal prevention because HIV antiretroviral therapy will primarily prevent progression to AIDS and obviously causing premature death in those individuals who may not be on therapy. And also the idea of decreasing the risk of transmitting the virus to others. But the impact of treatment after the introduction of treatment as prevention, we continue to see further increases on the uptake of antiretroviral therapy depicted here on the turquoise line. To the right side of the dotted vertical line showing the introduction of STOP. And again, concomitant to that, we continue to see decreases on the new HIV diagnosis. And particularly important here, if you look at the yellow line that shows that significant decrease among those individuals who were recorded are using intravenous drug use being an intravenous drug user. And interestingly, also on the blue line, which shows the increase of the number of syphilis cases in the province. So despite efforts across the province, syphilis continues to be a significant problem while the scale-up of antiretroviral therapy has led to decline both on the new HIV cases, as I depicted in the first chart, and in the second chart, continue to see a decline on the right side of the dotted line, a decline on the AIDS-related cases and mortality. So significant improvements over a period of time. But when you're working with STOP HIV, working with Julio, working with Irene and others at the center, we don't sit and congratulate to these successes, but we look at where are the gaps, where can we be more effective. And this chart actually is a study led by Dr. Viviani Diaz-Lima at the Center for Excellence, showing the progress, how the province initiative gradually accelerate the treatment initiation. On the bottom part of the chart, you'll see the median time in months, and the vertical shows the various years. On the orange color, you'll see the time from diagnosis to initiation treatment, and on the right side, on the green arrow, you'll see the time from initiation of therapy to viral suppression, which was the ultimate goal to benefit the individual and the population. And if you recall, we started about 200 CD4s or less before we offered therapy. And at that time, there was about 27 months average from diagnosis to being suppressed. Gradually, it was being dropped as we introduced changes on the guidelines and modified the 200 to 350 and to the post-stop HIV/AIDS, where we actually stated clearly on the guidelines that treatment should start regardless of CD4s. And that shows that decrease from the 27 months from diagnosis to treatment suppression, dropping to a median of 2 months, which is a significant improvement. That really means closing the window of opportunity for people to transmit the virus when looking specifically at prevention. So as many of you are aware, HIV incidence is difficult to measure and can only be estimated. And this is another estimate provided by Dr. Viviane Diaz-Lima and used by Julio most recently, forecasting from 2019 to 2022, the decrease on the HIV incidence, estimated decrease on HIV incidence. And it is now forecasted that for 2022, there will be about 122 cases only across the province. That from about 700, an average of 700 new diagnoses at the time of the peak of the epidemic in the mid-90s to less than 100, to about 122 shows that it's about 85% decrease on the new cases. I didn't want to leave this aside because one of the main concerns that were actually brought forward at the early stages of the launch of the STOP is how the clients will feel about being treated earlier than what we were doing at the time. The treatment seen here in various dimensions was clients participating in this study pointed out that favorable treatment experiences, so they benefited widely in many aspects of the treatment, but also at the right side shows that more timely HAART initiation and timely viral suppression in tune with the previous chart that I just showed you. Now, where did we went from there? And when I show you the most recent data for the decrease of HIV new diagnosis and AIDS cases, the pilot project was scheduled to last for 3 years before any decisions were made. And along the second year, the Ministry of Health actually made a decision to roll out across the province because the benefits were so great. Later on, Julio has also managed to champion these ideas across the international community, and the UNAIDS embraced the 90/90 targets. And here in this chart, with using some preliminary data now being released by Health Canada, in the left side of the chart, you see the benchmark, which is the 90/90/90, and in the 90% diagnosed in the dark column, and 90% on treatment on the blue color, and 90% virologically suppressed on the gray color. And then compare with the rest of the provinces. And by using this metric, as you can see, BC is the only province that not only embraced Stop HIV/AIDS very early, but is the only province that is actually meeting the 3 targets. And perhaps I should qualify that by saying the only large province that is meeting that, because smaller provinces on the East Coast, so in the East Coast and also the territories have shown also achieving these targets. Now, Julio will also challenge this idea because the 90/90/90 really translates into 90, 81, and 73%. In other words, people may actually be doing well in treating individuals, but they may not be doing as well in diagnosing. So in this case, this 90/90/90 converted to 90, 80, 81, 73 shows that only BC is leading the pack here, while the other major provinces are showing significant shortcomings into some of these performance metrics. As we move forward towards the conversation section of this presentation, I will hope that my colleague, Irene Day, who also work alongside Julio and myself and others in the launch of Stop HIV/AIDS, will turn this into a conversation and address the two other goals of this presentation. Thank you very much.
Thank you, Rolando. It's lovely to be here with you working. I wanted to go back to one of your slides. You don't have to go back to the slide itself, but I want to reference it. And that was in particular in 2006, when Dr. Montana was in Toronto at the International AIDS Conference. And he was presenting on this concept. And it was a challenging time because not everybody was receptive to this concept. I specifically remember a conversation that we had next to the conference hall at the International Continental Hotel. And we were meeting with Stephen Lewis, who was then the UN Special Envoy for HIV/AIDS in Africa. And Julio was showing him the presentation. And I so remember this. And Stephen Lewis jumped out of his chair. He rolled up the presentation and he hit Julio on the side of the arm and he said, "Why haven't you been doing this sooner?" It was really such a magnificent moment for a recognition of the impact of reaching out and engaging into treatment and care individuals who were diagnosed at the beginning with HIV. So there were moments like that throughout this time when we were working with a variety of people. And actually at the same conference, Julio was invited to meet with the then President of the United States, Bill Clinton, to talk about this whole concept. So it was really important to get that message out, not just in British Columbia or the rest of Canada, but internationally as well. So in keeping with that concept, Rolando, there were some unique characteristics from this whole time that we worked on this that I think were key. There was 4 things. I'm wondering if you can talk about some of those key characteristics that you thought were brought to this program.
Yeah, thanks, Irene. I would suggest that it's more than 4, but we don't have time to go over all of them. But certainly, if I focus on the top 3, 4, I would say that the number 1, which is still true today for the evolution of Stop HIV/AIDS and expanding this concept into other conditions, is a strong leadership. And you preface already your introduction by describing what Dr. Julio Montana have done and the importance of rallying around key influence or key individuals that could influence decisions. And certainly having Julio repeating and having been working along Julio for many years, and particularly in this initiative, emphasizing and repeating the message at every single opportunity, regardless of whether the individuals knew or didn't know, it was extremely important. So I would call that relentless leadership, a strong voice that can stand up and address the issue, able to articulate the science behind these concepts in a way that both public but also politicians and policymakers are able to understand. I think that the other aspect that really helped the Stop HIV/AIDS in British Columbia was the dedicated funding that the ministry put forward in addressing this issue.
I think, Rolando, let me just add to that point about the dedicated funding. That funding was new money that was provided to the health authorities. And you made reference to the fact that 3 years into the STOP project, the then Minister of Health, who was Margaret McDermott, announced that we were ready to roll it out provincially. This was huge in terms of the recognition of the success that the pilot was having. So the funding was dedicated funding for the health authorities, where they didn't have to take that out of their existing funding. That's really important.
And that was key. Yeah, I agree, because quite often there's new initiatives, whether are local by health authorities or provincial in nature, which comes with no dedicated funding. And what it really means is the health authorities have to struggle to get some of these resources, and usually there's not much progress into implementing changes. In this case, was unique and was, ambitious, but also significant funding, because $48 million for 3 years it was a significant injection of funds into this into the healthcare system. Another key issue that we experienced was the engagement. You talk a little bit about the engagement with policymakers and international players, but also at a local level. I recall having town hall meetings with key stakeholders, particularly from the community. Some individuals engaged on the health services, but particularly from the community, and how they also understood the benefits of this and rally around the support for STOP on the early days. And I would say even up to now, they remain very supportive.
I think there were some key groups that were involved in that. Positive Living BC, Positive Women's Network, the Assembly of First Nations, the BC Union of Indian Chiefs at that time were hugely supportive. And in fact, we were at a meeting with them in the early days, and I remember distinctly sitting at the table during a meeting, and they crafted a resolution to support the STOP project right there with us present. It was a huge moment of being supported. So we had the presence of these groups, AIDS Vancouver, the Dr. Peters Center, representatives from the government like Perry Kendall, who were so supportive of the work that was being done by the BC-CfE. It really helped the implementation of the STOP HIV program.
And I think the other key element of the work that we have done is also unique, in not only to this project, but in the province and across the many jurisdictions, is the ability of the center to develop it very early. And again, the vision of the early days when the center was funded and forming what is now known as the DTP registry, or the HIV register across the province. And that led us to generate the evidence that was needed to support not only the conceptual ideas, but also to continue monitoring and evaluating and designing some key interventions that will help to close those gaps that we just suggested. So a good example is the charts that I show you depicting the discrepancy on the benefits of the decreased mortality across the province, and that really came out of the analysis done at the Center for Excellence, which determined what were the jurisdictions involved in the pilot project, but later on to inform the system and roll this across the various other health authorities.
Of course, Rolando, those are good things that have happened as a result of the STOP project, but it wasn't all roses in terms of getting the program implemented. Can you speak a bit about the challenges that we faced during that time?
That's a very interesting question, because there are so many things that also were on the way. So it's very interesting, because we saw also as unique having dedicated funding to do this implementation of the pilot project, and later on the rollout across the province. But it always happened, when there is no money, you fight, and when there is money, you fight harder. So there was some concerns about how the money was being distributed, and why some people got more and some others got less, and why needed to invest more on treatment or in diagnosing and so on and so forth. But this was actually mitigated through a series of collaborative meetings and discussions that we ended agreeing to what we had. But certainly that was a significant and interesting challenging, because it was something that we didn't expect. Another challenge that I think is still, it was at the time a very important issue, was the concern brought forward by many kind of individuals who were traditionally involved, or who were involved in the traditional way of prevention in the public health sector. I distinctly recall being called as someone who was not supportive of prevention. And I pointed out the fact that my training is in public health, and this was a different type of prevention, but certainly an important way of looking at prevention, and particularly because the traditional prevention has shown that either had contributed or maximized their contribution, or they has stalled into halting the new infections. And so certainly the evidence was quite fundamental. Challenges with having additional access to data that also help us to understand better what the trajectory of the HIV epidemic was happening at the time was also problematic. It took us several years before we were able to get the data that we needed and form what is now known the STOP HIV/AIDS cohort, which actually has helped to provide the feedback that is needed for the provinces, various regions in the province to implement their programs and monitor their programs. We also have different players bringing different perspectives, and that's good because it helps to build stronger programs, but it also creates some tension and stresses at the beginning. And I mentioned a little bit about the prevention and the view of prevention, and these notions that, you know, focusing too much on treatment will medicalize the prevention side, or emphasizing more treatment, it will ignore the psychosocial needs of individuals, which was never the case, because later on proved that having this additional funding and investments led to the formation of outreach teams and intensive case managements across the province that are currently benefiting the individuals and addressing their psychosocial needs. I think the other challenge that I think you and I noticed, because we did a lot of traveling across the province and meeting various local leaders and local health system leaders, is the fact that there's a lot of times, you know, people are supportive, but their organizations might not necessarily be behind their decisions of support these ideas. And so it took quite a effort to align those two things, not only the leadership but also the local staff. And so I think to some extent we were able to mitigate a lot of these challenges to the point that we showed in the early slides the success that STOP had, not only the pilot project earlier than expected, but also the STOP HIV/AIDS implementation, the overall implementation, as I noted in the last few slides, showing the progress towards the 90-90-90.
I think from my perspective, an important thing for us was the implementation of a communication strategy. And that was, just as you were talking about, meeting with not just the leaders in the health authorities, but really ensuring the connection with the community, because it was so important to have that buy-in in order to implement a strategy that was a bit foreign to them. I think, Rolando, you played a significant role here in that, in terms of the development of the collaboratives. And I'm wondering if you would talk a bit about that.
Yeah, I'll do that. Before I do that, I'd like to just follow up in your previous comment, because I think it's quite relevant. And this is what I think the system eventually will recognize the credit that Julio has by bringing all these ideas together and being able to rally around the community and the policy makers and finding the resources to implement and proving that this actually works. And not only in the paper in terms of, you know, the randomized clinical trials that were released in 2011, but in real life at a population level. So if anything, my role has been more focused on that area and the population level. So how we, and I usually tease Julio by saying, you know, Irene and I usually get to sit with you and unpack your idea. So how we actually bring that idea down into the operational and the implementation side. And this is what really happened. So the quality improvement was an instrument to do that. And it was aimed at bringing the various teams across the province, bring them together, having some common ground in terms of, you know, what clinical guidelines are we using, what is the the treatment guidelines that will guide some of the implementations, noting where the gaps were. If you were to go back on time and look at the cascade of care back in, say, the pre-stop era, we were probably only treating about 30% of the population. Now we have reached 90%, right? So that has been a significant change. Similarly, identifying those gaps require a methodology that is respectful of the differences that are across the province, and obviously the resources that local teams can actually avail themselves. And this is how we launched that using the breakthrough series from the Institute of Healthcare Improvement from the US. And we actually brought 2 collaboratives that closed those gaps, and particularly focus on treatment initiation and viral suppression. And later on, these various quality improvements were used also to close gaps in other services. So that was also another mechanism to engage clinical teams across the province. And I would say not necessarily only clinical teams, because also the client voices has been a very important component of that, but also other agencies that were supporting some of these individuals.
So one of the key components is reaching out, engaging and sustaining individuals into care and treatment. There were some other projects that you worked on that helped with this.
Well, I must recognize that the local work done by the health authorities and the various programs and setting some of these key elements, because the center is not able to deliver direct care, or at least not we do in some extent, but not at that level, at the individual level. So working with the health authorities and not only providing some support and advice and data, they were able to create the outreach teams, the STOP outreach teams in many jurisdictions, together with intensive case management and improvement on their partner notification. And those individuals who are named as partners of those who are newly diagnosed, and improvements on that led to some of those points that you just made. But more specifically, the Center for Excellence also engaged with an initiative called Retain, which is re-engage and engage individuals newly diagnosed or previously diagnosed but not retained into care and treatment. And that initiative was actually is in partnership with the medical health officers of each health authority and the local HIV/AIDS programs. But it was reviewed and approved by the various privacy officers, and including the commissioner, the privacy officer commissioner in British Columbia. And it consists mainly on sharing some of the names of individuals who have been disengaged after a period of time with these outreach teams for the purpose of outreaching those individuals and trying to be less disruptive as possible by approaching first their clinical providers and their treating physicians and nurse practitioners, and moving into doing that outreach that is needed to re-engage them. And what we have seen is a decrease in the number of months that people are off therapy, but also we have not seen any negative consequences. So we have not seen any reports of breaching confidentiality or people feeling threatened by that. To the contrary, some of the early qualitative data that we have show how people feel value when they are reached out and engaged into care and treatment.
Rolando, sometimes people get confused with the concept of STOP HIV and treatment as prevention. Can you just talk about that a little bit?
Well, it's been an evolution from seek and treat to formally call it STOP HIV/AIDS to treatment as prevention. Seek and treat obviously means that we are proactively trying to identify those individuals unaware of the diagnosis, engage them in care and treatment, while treatment as prevention is focused on using that therapy or established treatment to prevent either the progression of a particular disease or prevent new or transmission of that disease in many ways. But it also involves concepts that Julio has been championing, which are the idea that treatment as prevention works not only for infectious diseases, but also for contagious diseases. And contagious diseases, when there is some behavioral components that can be prevented by certain interventions. So smoking is a good example of how, if you have a group of teenagers together and 9 out of 10 smoke, it's more likely that the one who does not smoke will end smoking. Similarly, if you have people in a family that are using a particular substance, whether it's alcohol or drugs, it's more likely that their children or the other members will also end, if not all, some of them using some of these substances. So how you use some of these interventions to treat that individual, to modify that behavior, so eventually stop that kind of contagious to the rest of their the social network group.
So it's we're looking at STOP HIV, treatment as prevention, and treatment as prevention segueing into a targeted disease elimination strategy.
Yeah, so that's using this, the targeted disease elimination is now talking about using some of these specific concepts for a specific condition. So for instance, for hepatitis C, you could actually talk about targeted disease elimination if we were able to treat all or the vast majority of those individuals with hepatitis C who are transmitting the virus, and not only for their own benefit, but of stopping that transmission from ever happening again. Of course, there's other conditions that needs to happen, the willingness to be treated, access to harm reduction so they don't reinfect and so on, but that's the concept. But there's one more, which I think is probably involves all, but it is really distinct, is the idea of healthcare sustainability. And it's an important factor because if you look at this from the Stop HIV/AIDS and where are we going with the decrease on new infections and decrease in morbidity and mortality, and significant changes that happen alongside, which is the transformation of the former AIDS world at St. Paul's, for instance, is really returning resources to the healthcare system that need to be deployed to other conditions that are also present in the system. So it's also the fact that by having little to no new infections of a particular condition or diagnosis of a particular condition may lead to less healthcare utilization that could be deployed in other conditions that are still inevitable.
So what you're talking about here, to me, is a legacy of the STOP project.
That's correct. So,
yeah.
So I think the legacy, you can look it up from various perspectives. One is mostly at the local level, the way we improve the population's health, but also how this has influence across the country and internationally as setting these international policies. So that's a legacy that will last for long, particularly as new investments in HIV/AIDS are being made internationally, but also importantly, how we are being moving some of these concepts into other conditions. And for those who know me, they would know that it's not out of luck or randomly that I have used some of these concepts in optimizing the opioid use disorders, particularly the opioid agonist therapy across the various programs that I have to work with at a provincial level too, has been embraced in different jurisdictions, but also most recently also looking at improving the treatment optimization of psychosis using the same ideas and same methodologies, right? So why people should suffer waiting for so long before they're being treated with the treatment is available to them. Yes, there are some risks on therapy that are usually weighted and discussed with the client, but one offer, what the experience has always been that when you offer clients or patients certain interventions, despite the risks, they tend to take it. So the problem is that we have in the system is that many times we just don't offer. We make the assumption. In the early courses, the course of the HIV Seek and Treat, if you recall, we have significant challenges with HIV testing, for instance, where there were so many barriers to test people with HIV. It was risk-based, meaning that the providers have to ask the individuals to disclose the risk to then advise them to do the test, to move into a more kind of normalized, so to speak, offering of the HIV test, resulted in a significant increases on testing, and obviously the case finding that was needed at the time and to ascertain also the fact that the decrease in new diagnoses that we're seeing is not because we're not testing. In fact, we're testing more, and we're still seeing less cases.
There's no doubt that the concept of treatment as prevention has been adopted in many countries. The first, of course, being China, and in my estimation, that was one of the most significant. Brazil, Panama, Queensland, Argentina, parts of the US, France, a number of places. But why do you think it's so difficult for the rest of Canada? Your slide talked about the success that the BC-CfE has in terms of the 90-90-90 target. But if you look at the rest of the country, they're not doing nearly as well as British Columbia, which is the home of treatment as prevention. So why do you think that is?
I haven't really worked on those other provinces, so I'm not able to say definitely what the reasons are, but one has to wonder about the ideology and the political ideology. So while we in BC enjoy from a significant support from the various governments, and doesn't have to have a particular banner, but they have been very supportive of the work that Julio has led and we have implemented in BC. So you don't see that in other provinces. We're certainly sharing with many of the provinces our challenges and successes. We're sharing all the documentation that we have from the various business cases and programs that we have made. Our website on the Stop HIV/AIDS lists all the documentation and the various interventions. The CFE site also has all of this information. So I think it's one of a political will and the desire to address this as a priority.
One of the questions from the audience is, I wonder what you think about the POCT patient being able to do this at home. Does this worry you?
No, I'm not worried. I think it's a natural evolution of what we have done. I think this is what I was just talking about. POC stands for point of care HIV testing. That's what it means. And being home-based meaning that as we've been testing for COVID lately, for instance, when we do our home-based tests, it's a similar idea. So what we knew very early on the HIV, on the Seek and Treat initiative is that when people know their HIV status, the vast majority of them, if they learn to be HIV positive, they change their behavior. So it's extremely important for individuals to learn their HIV status because they will change their behavior to protect their potential partners. And so what we noticed at the time is that the policies in place were not able to embrace the HIV testing as we wanted it to happen. In fact, at the time it was estimated that about 50% of the new infections were caused by about 25% of people unaware of their HIV status. So being aware of their HIV status is important and relevant. Secondly, the benefit in BC, I would probably question it, mostly because we have managed to, as I showed you during the presentation, decrease the number of new infections. But like I suggested, any new infection that is detected and the individual is aware and ideally put early on therapy will not only be the benefit to the individual, but also close the window of opportunity for transmission. So I'm not worried. I think that probably epidemiologists and others may be worried about it because it may actually, some individuals may not necessarily seek care after they tested positive or entertain this idea, but it's started to be used across the world, and I think we'll see more of that.
Rolando, a couple of years ago, Dr. Montana and Minister Adrian Dix opened officially the 647 research laboratory. And at that opening, they announced the elimination of AIDS. What do you think the reception of that was, and what do you think the impact is?
Well, I think one has to distinguish between HIV and AIDS. You know, AIDS is the manifestation of the late HIV infection. And we are very early on the launch of the Seek and Treat. We envisioned that the first step was to stop or eliminate the number of AIDS cases across the province, because that was a proxy for saying people are presenting late and they may not benefit from the treatment at that stage. And so therefore the importance of doing that. So it has a significant connotation in terms of policy, because it refers to one of the components of the strategy. What's the uptake? I think varies, and varies because, as I suggested, there's always various views of how this is being taken. Talking about AIDS elimination may actually decrease the noise of the agenda of other organizations. But for us, we continue to be focused on the outcomes that the desired outcomes, which is the improvement of the health status of the population, particularly the people who was living with HIV/AIDS, and that was a major goal. And of course, secondary to that, we've seen the other gains, which includes decrease in new diagnosis of HIV/AIDS.
So if you were going to change anything about this whole process, Rolando, what would you change?
I don't think I will change anything, Irene, as much as we talk about some of the challenges before. But I would say that to some extent I would have liked to see more jurisdiction of how the funding was being deployed across the province. But I also understand the need to balance to the local realities of the various programs and services. So I think that's something that perhaps would be the only consideration I would have. But I consider myself extremely lucky to be involved in this initiative, because it's really helped me to shape my mindset and the work that I did then, but also the work that I'm doing now and I'll be doing in the future. So I think we can talk about a lot of the things, but we actually managed to overcome them. So I wouldn't say nothing was unexpected. Everything actually was as we thought it was going to happen, and it was just an issue of navigating some of those issues.
Okay, Rolando, we have another question, and it's a two-part question regarding point-of-care testing. How will patients find you if they test at home? Is the first part of the question.
So it's not different than what I would say how the patients will find you today if they have COVID-19, right? So I think it's about education and providing resources and availability across the system for those services. And of course, we are in a situation right now where we seem to be challenged by the shortage of family doctors and nurse practitioners and nurses and pharmacists, and it seems like all the human resources available. But I think the key element of this is to ensure that individuals are aware of the services that are available to them, and they have some degree of access or easy access to such services.
And the second part, is there a plan for capturing those patients, i.e. self-reporting?
So usually I have to clarify that the first part of the question was my opinion, and my opinion is not necessarily just a policy in place. So my opinion is that HIV testing has evolved over the last several years and is evolving towards incorporating the point-of-care testing eventually. So that is yet to be reviewed by the proper policymakers, which is people who develop the HIV testing guidelines, and then incorporating into the various practices. So at this stage, I would say, although I'm supportive, it's still not a policy, and therefore I wouldn't assume that it will start tomorrow. But I'm aware that it's in other jurisdictions, particularly in the US, has already started. And so whether the question is always what matters the most, is statistics or the individual. So to me, it matters most the individual, and if the individual learns their HIV status, seeks care and treatment, is more important than a statistic somewhere else.
Well, we're almost out of time. We are out of time. It's now 1 o'clock. Rolando, thank you very much for your presentation. It's always a pleasure to be working with you.
Thank you for the opportunity. Yeah, thank you.